So again, good morning. This is Ellen Barra with the WPS Government Health Administrators, Provider Outreach and Education Team. With me on the call today, we have several of our provider outreach and education colleagues. My friend and colleague again, Mary Muko, is going to be watching our chat. We also have on the line with us today Dr. Joelle Vahakas, who is one of our contractor medical directors, and she'll be providing some information to us here in just a second also. This is the disclaimer that we provide with all of the presentations that we do. Medicare rules do change often. And so the information that we have for you is as accurate as we can make it as of today. The Medicare rules and regulations, though, are what determine whether or not Medicare can make payment. We will respond to your questions. We want to give you the information you need in order to be able to bill for these services successfully. But we will respond to those questions based on the information you're providing to us. Medicare rules and regulations, again, will determine that final coverage. And then CMS does prohibit recording of presentations for profit-making purposes. So if you are recording, if you're taking pictures of the screens, something along those lines, we would ask that you discontinue doing that. So with that, I'm going to turn it over to Dr. Joelle Vahakas, again, one of our contractor medical directors. Joelle?
Thanks so much, Ellen. So by way of background, I'm an internist and a pediatrician who worked in rural practice in the past, then moved on to hospice and palliative medicine, which I practiced for the last decade or so. I have a real interest in providing high quality care regardless of someone's ability to pay. And this project really works very nicely in that regard. We know that chronic care management, when it's applied, really does make a difference for our providers and our patients. For our patients, we know that when they enroll in this holistic care, they have fewer out-of-pocket costs, fewer disruptions with things like emergency department visits and hospital stays, fewer crises, and a better experience of the care. What I didn't expect as an internist and pediatrician when we started this program was the impact that it might have also on providers of that care. I was surprised when I was speaking with providers that a lot of them described for me feeling very satisfied with this type of practice, that it allowed them to focus more on the patients in front of them. They were interrupted less often with their sickest patients in crisis. They also felt that they were able to deliver really good care. And that is really my motivation for wanting to talk to you about these programs. Next slide. So we know within our Medicare population, and that's usually typically people 65 and over, but it certainly involves some other folks as well. But within that population, about 2/3 of them, somewhere anywhere between 58 and 66% of them, will have 2 or more chronic conditions. And that is the one of the requirements for enrolling in chronic care management. We want those conditions to be serious and affecting one's life. But what we know is that even if you take into account that perhaps this cohort of patients maybe isn't, quote, that sick, we know that very many of them would qualify for this program. And despite the fact that such a high percentage might qualify, usually around 2% of our patients who could qualify actually get chronic care management. So we're very interested in making that different. Next slide. All right, so chronic care management is holistic, proactive, and it's different than our typical model. The way I was educated in medicine, our paradigm is problem focused. And that's great. You have a problem, you come in for a visit, and as physicians or providers, we provide for you hopefully some form of solution or on the way to a solution. We know that though this kind of care is a different approach. So rather than being reactive to a problem, it is more proactive. It is really about what can we do to assist patients such that they have fewer problems longer term. The other thing that makes this different is rather than think about what we lack in terms of what we have for patients, we think about what we do have. It is a strengths-based model of care, very dependent on the community around the patient, including the family, and very dependent upon resources that typically providers might not consider because they are simply outside of their office or practical clinical setting. When we do these things for patients, we know, of course, that they have fewer crises, leading to fewer emergency room visits, fewer hospital stays, and lower out-of-pocket costs. And my colleague Ellen will probably share this with you again, but it's really very significant. One hospital stay could pay for upwards of 5 years of what a patient might pay for chronic care management. It's also a better experience for them. For providers, and this is very important, Medicare has assigned value to these activities that perhaps physicians and providers did without even thinking about it, but are definitely work. Anything that someone does to respond to a laboratory that needs to be adjusted, some symptom that worsens that they know about over the phone, all of that has value. And Medicare wants to reimburse providers for the work that they are already doing. We know that application of this kind of care leads to less fragmentation of healthcare. And as someone who is a physician and worked in the hospital setting for the last few years, I can tell you that fragmentation of healthcare doesn't just impact patients in terms of care discoordination, but it also leads to a lot of extra work for providers as they try to wrangle in all that's happened to a patient, all that medication reconciliation every time there's a change in condition. All of that adds to the work and congests the workflow of a typical medical practice. When we streamline some of these things and get rid of some of this fragmentation, providers can have time for more in-person visits. And this is a benefit to the practice as well as the want to come in to see them. The other thing that I think is wonderful is an appreciation for the skills of your clinical staff. Most providers are providing this kind of care with supervision of their clinical staff, but they're very much building trust between themselves and the clinical staff as these clinical team members are simply representing the physician and their advice, their wisdom to the patient. Sometimes proactively, simply reminding them to get their flu shot and that sort of thing. But it is an extension. And a lot of providers have told us it feels like a true extension of themselves. It allows themselves to reach more patients in a more skilled and appropriate way. And this leads to a better experience for providers. I do like to talk about quality of life in terms of quality of work life. And I think quality of life is really important for patients. I mean, doing palliative medicine, that is in part one of my core values, but I don't think it's a trivial thing to consider quality of work life for physicians too, especially in this day and age post-pandemic. Many of us have suffered burnout to our core. We love medicine, and yet we often feel overwhelmed and feel like we're not making a difference. Chronic care management actually helps providers feel like they're making a true difference for patients. It allows us to practice medicine often the way we really want to, in a way that affects change and helps patients lead healthier lives. Next slide. All right, so if this is such a great program and leads to such wonderful outcomes, how come we're not doing all of this chronic care management? Well, sometimes it can be hard to identify patients There are different ways to do this, and Ellen will talk about this, but you can, for example, consider your sickest patients. And if you're not sure who they are, ask your team, ask your clinical team, ask your front office. They will tell you who calls the office most often. You probably know also how many of these patients come in and maybe have a hospital visit in between your visits. Most of the physicians I know have practices such that they could probably rattle off 5 to 10 patients off the top of their heads that they know could be their most ill patients. Some providers also find that it's a good way to collect patients by thinking of a single diagnosis that they'd like to work on. Heart failure, for example, or COPD, or patients with a concomitant oncology diagnosis. They might cohort into this program. You can also do things like survey your patient list for the day and do that routinely. That's often also a best practice for people to identify patients for this. The other issue is you do have to consent patients for this, and there are lots of good reasons why, and Ellen will review those. But one of those is cost sharing, and that can be a bit of a sticky wicket, especially if patients are used to calling the office and having their needs met without a charge. But convincing them to be a part of this program is a little bit of an art form. Remember that some patients appreciate written communication, some appreciate verbal, some need some time to think about it, some need some time to think about it with their families. So be sensitive to how patients might make medical decisions in general when you think about talking to them about this program. Sometimes it can be helpful to talk about it, the program, and let them know that you're thinking they might benefit from it. Then you'd like to let them know a little bit more and then talk to them in person the next time. We also find it can be useful if when they're in the office, that they meet the clinical team member who would be their care coordinator while they're in the office with you. Some physicians even go so far as to have that team member be a part of almost the entire visit the first time that they introduce it. Whatever's comfortable for you makes sense. Then there's also what we're most interested in is how do we get our patients to have chronic care management when we know those who need it the most do not receive it, meaning that the patients that we know live in what we determine to be a high area deprivation index. And that's referring to zip codes and the like, where there may be issues with housing, there may be food desert, there may be low income, there may be even air quality issues. In those areas, we know where it's perhaps most difficult to access care, perhaps most difficult for patients to get transportation. Those are areas where people could really benefit from chronic care management, and they tend to get it the least. So we're very interested in figuring out ways to develop bridges with those patients. And then there's the how. If you've decided, okay, I'm willing to jump the hurdles for chronic care management, what hurdles are there really? Well, there's the time. Providers these days are very reluctant to give up time to learn something new. And I understand that. Sometimes you just don't have the brain space to occupy one more difference in workflow. However, I will tell you in general, what we hear from providers is that it's worth it to accumulate the skills and the like that you need to do this program well, that the time benefits ultimately outweigh the time investment. The other thing to think about is your billing and documentation, how to support it. And Ellen will go over what is required for successful billing. And then staffing and staffing issues. We understand in this era that no one is overstaffed. We understand that this can be an issue for everyone. However, we know that there are some tricks of the trade, people who have done this successfully. And if you're hesitant to do this, there's programs that you can access that will do this outside of your office, but there are some considerations when you're doing that as well, which Ellen will review. And then making sure your electronic health records are able to keep up with the needs of your billing and documentation. Sometimes that's a hurdle as well. But what we're finding is most practices seem to be able to adapt their electronic health records, even if it's designing a separate health record for this particular program. Next slide. All right, and this is something, again, that's a concern to most of us in healthcare. We know that if everyone doesn't have access to good healthcare, then we have a system that's inequitable for all. So we're keen to look at these ADIs, this Area Deprivation Index. If you've not done it, I would encourage you to go to the Neighborhood Atlas site, and we'll have a link to that, and look up your own zip code. It is extremely instructive. You can look up based on your state, and then you can zero in on your locale to see where you are. I think most of us, if we've lived in an area for a time or two and we're invested in that area, could probably pick out and guess which areas of our neighborhoods are going to be in areas where healthcare access is difficult. We are interested, especially in those who've maybe solved that riddle of how to get CCM or chronic care management to the patients who need it the most. If you had, we certainly want to hear from you. Next slide.
Okay, thank you, Dr. Vahakas.
Oh, thanks, Ellen. And I am going to have to sign off. I'm actually out of town attending a meeting, but I wish you all well, and I leave you in excellent hands. Thank you so much for attending. And please remember to fill out your surveys so we know what we can do better. All right. Thanks, everyone.
Thank you, Dr. Vahakas. We appreciate you joining us today. So what is our objective of this presentation today? Well, one of the things that Dr. Vahakas mentioned is that chronic care management are services that you're probably already providing to your patients. Your patients are calling in, they're leaving messages for your clinical staff. The clinical staff is taking the time to call them back to address whatever issues they're having at that time. Your patients are calling in requesting a more frequent visit where you have to work the patient into your schedule for the day. And so chronic care management really is a structure that you can use in order to receive reimbursement for all of this work that you're already providing to your patients. And so what we want to do for you here today is really to talk about that structure and then to explain the coverage requirements and the coverage guidelines and the billing aspects of chronic care management itself. And so that's what we're going to be talking about: who's eligible for chronic care management as far as the patients are concerned, who could provide chronic care management as far as the practitioners. We're going to talk about an initiating visit and when that's required, the care plan itself and how you develop that, and then your monthly actual care management service and how you bill that to Medicare. So let's talk first about who is actually eligible for this. Well, for chronic care management and complex chronic care management, the patient has to have 2 or more chronic conditions. They're expected to last at least 12 months or until the death of the patient. These chronic conditions will place the patient at significant risk. Now, I saw that Mary just put in the chat a link to a CMS document on chronic care management services. As part of that document, they have examples of what could be considered chronic care or chronic conditions. That's not the entire list. Those are just some of the examples. Any diagnosis that the patient has, if it meets what's on your slide there, expected to last at least 12 months or until the patient's death, places the patient at significant risk of acute exacerbation, functional decline, or death. Now let's think about that for just a second. If one of our chronic conditions is diabetes, diabetes fits this requirement. A diagnosis of diabetes can place that patient at significant risk. For 90% of your patients, once they receive a diagnosis of diabetes, they are going to continue to have that diagnosis of diabetes. So your patient does not have to be in crisis in order for you to begin providing chronic care management and complex chronic care management. As Dr. Vahakas mentioned, providing these services really is a way to prevent that escalation, where the patient may end up with kidney problems or an amputation or something like that. With doing chronic care management, you're actively working with your clinical staff and that patient on quality of life, on preventing things from getting worse, all of that kind of stuff. And we'll talk about how that works in a second. For principal care management, this one is a single high-risk condition. Now, you'll notice that different wording. So this one, that condition is expected to last at least 3 months or until the death of the patient. This condition is generally going to either have led to a hospitalization, or there is a very real chance that the patient will need hospital level of care in order to deal with this condition. A patient could also require frequent adjustments to medications, or the condition is so complex due to other comorbidities that the patient has. So you have chronic care management, which is going to apply to a greater number of your patients, and then principal care management for those patients at higher risk because of that single high risk condition. So now let's talk about who can provide this. Well, physicians and non-physician practitioners can provide this. These are MDs or DOs, limited licensed practitioners, such as a podiatrist, excuse me, or a chiropractor cannot be the billing provider, but both physicians and non-physician practitioners can be that billing provider. Rural health clinics, federally qualified health centers, and hospital outpatient departments can also bill for these services. And as we get a little, excuse me, as we get a little further into the presentation, we'll talk about some of the differences there. The services, however, are going to be provided for the most part by your clinical staff and are going to be provided in a non-face-to-face setting. So this is not the patient coming into your office and you having to work in another face-to-face encounter or another telehealth encounter. It really is conversations and work done by your clinical staff under the billing practitioner's general supervision. And we'll talk about the Incident 2 guidelines in just a little bit. So what are some of the CCM service elements that have to be met? Well, the patient has to consent, as Dr. Vahakas mentioned earlier. There are certain pieces of information that have to be gathered in a certified electronic health record. As part of the care management service, you're going to manage transitions. So this could be the patient being released from the hospital. It could be the patient being released from a skilled nursing facility, emergency room. It could be sending the patient to another physician or practitioner for a referral and additional information from that practitioner. And again, it's your clinical staff that are generally going to be providing these services. Not that your physicians and practitioners can't, they certainly can, and we'll talk about that when we get to the procedure codes, but it's generally going to be your clinical staff. And then the patient does have to have 24/7 access to that clinical staff. Now, there's several different ways that you can do that. You can have a clinical staff person who is on call with maybe a separate telephone number that you provide to that patient. It could be where you have someone monitoring your portal. So if a patient that is involved in or enrolled in your chronic care management, then someone is watching for information from them. You can use an answering service as long as your answering service is aware that they could have patients on chronic care management, and then the answering service would get them to that clinical staff. For after hours care, again, the answering service, or you can use maybe a care management organization who's going to provide after hour care, maybe clinical staff from your local hospital who are available to provide that clinical care to that patient after hours. And again, that has to be under the Incident 2 guidelines, which is where you really have a contractual relationship with this clinical staff and could be a W-2 employee, um, could be a contracted employee or entity that you're working with, etc. So the first thing that you want to have is that discussion with that patient. You can't provide chronic care management simply because you know it's a good idea. The patient has to actually consent to that. And they consent to that, number one, because there is cost sharing, as Dr. Valhakis mentioned. The patient's portion for chronic care management and principal care management, anywhere from $12 to $20 for each monthly service that you submit. But as Dr. Valhakis also mentioned, that pays for a lot of chronic care management rather than paying the current $1,600 deductible for an inpatient admission. And that's the kind of conversation that you want to have with that patient. Here's what chronic care management can do for you. Here's what we're going to do. We're going to develop a care plan, which I'll talk about in just a second. There'll be activities for us that we're going to do for you. There'll be activities for you to do that will also help you increase your health, increase your quality of life. So the next thing that we have is an initiating visit. And an initiating visit is required for two types of patients. One is for new patients. These are brand new to your practice. And then for patients who have not been seen by your billing practitioner or a member of the same group with the same specialty within the previous year. And really, when you think about it, that makes sense that this is a requirement. You do have to have a relationship with that patient. You have to have information in order to develop the care plan. So the next slide that we have just provides what is acceptable as an initiating visit. You can see there the IPPE, which is the Welcome to Medicare visit, annual wellness visit, E&M service, and transitional care management. For rural health clinics and federally qualified health centers, the transitional care management is not an initiating visit for them. Now look at this procedure code, the G0506. This is when you're doing a comprehensive assessment and developing that care plan during that initiating visit. So it's only on the same day as that initiating visit. Again, for new patients, patients not seen within the previous year. There's no specific time attached to this, so your documentation would just have to support the comprehensive assessment and then the development of the care plan. It is an add-on code to that initiating visit, and then you can only bill this once, just at the start of your chronic care management service. So now let's talk about the care plan. Well, number one, it has to be patient-centered. So what we mean by this, if you have Bill, for an example, who has diabetes and they have hypertension, and you have Susie who has diabetes and hypertension, they're not the same. They could have other problems going on. They could have other environmental situations going on. So your care plan, whatever you need to include in that, needs to be specific to Bill and then specific to Susie. You want to capture all of the information that we're getting ready to talk about concerning the care plan, and you want to have that captured electronically so that you can share it. You need to share that with the patient. You can hand them a paper copy. You can load it on your portal. You want to be asking the patient how they want to receive that. In addition to that, you also need to be sharing with other practitioners who are involved in that patient care. When you're the billing practitioner under the chronic care management kind of umbrella for those services, you're really the coach. Okay, you're not out on the field, throwing the football or catching the football or running in for the touchdown. You're really the coach though, and you're overseeing everything that's happening for that patient. So that means you're going to be gathering information from other practitioners or other entities who have provided care to that patient. And then you're going to be sharing your care plan back with them so that, again, everyone kind of stays on the same page in providing the care to this patient. So let's talk about what goes into the care plan. Well, the first thing is going to be the problems. So these are going to be those chronic conditions, but it's also going to be other things. It's going to be things that you're treating. It could be things that someone else is treating. It could be things that nobody's treating. But anything that the patient is identifying to you as a problem for them, then that's what you want to include in that. Now, for some of your, I apologize for the coughing this morning. For some of your patients, some of the problems that they identify are going to be more urgent. So your care plan could concentrate on those a little bit more to begin with, but your problem list is going to be anything that your patient identifies. The next thing you need to identify is the prognosis for the patient. Now, when we think about prognosis, the first thing that comes to my mind anyway is a life expectancy. That's not what, or it's not the only thing that prognosis can include. This is what you're expecting to happen for that patient as you go forward. So for an example, if you have a patient and one of their chronic conditions is diabetes, what are you expecting? If they are well controlled right now, let us know in your document. Your care plan will identify what you're expecting going forward. If the patient is not well controlled, you want to provide the information in that care plan concerning possible wound issues, possible kidney issues, heart issues. Because again, this is information that you have in your care plan, but it's also information you're giving to the patient, and it really just kind of identifies for them in a document they can actually hold on to and look at. Here's what the doctor's thinking about. Okay, so maybe there's some things I need to do. The next thing that you want to identify are your goals for the patient. And again, the goals go back to those problems that have been identified. So for your patient with the diabetes, your goal could be you want their A1C level to be 6 or under. Your goal for that patient could be that they're drinking more water in order to support their kidney health. The goal for that patient could be that they're exercising 3 times a week. So those goals not only help you know and your clinical staff know what it is you're going to be looking for, but it also educates that patient and it provides them with information on, hey, wait a minute, here's some things, some really concrete things that I can do that maybe can really improve my health. And as part of your care management, you're talking with the patient about these goals, which kind of keeps it more in the forefront of the patient's mind. And then we have cognitive issues. If you're evaluating that patient either through a face-to-face or telehealth encounter, or through developing the care plan based on the medical record of that patient, and there's nothing to indicate in there that there's any cognitive dysfunction, document that. You'll just show that as part of your care plan. If you find that there is issues with cognitive dysfunction, then you want to use a peer-reviewed test in order to determine that level of that cognitive dysfunction. And then, of course, that will go back into your problem. It will go back into your prognosis and back into your goals, what you want to see happen with that going forward. You also want to look at functional limitations. Can the patient actually get into their bathtub or into their shower to take care of their hygiene needs? Can the patient raise their arm up over their head so they can actually wash their hair? Um, do they have functional limitations that make it hard for them to take care of their finances or to understand what a good nutrition plan is? So these are going to be the functional limitations that you'll document. For symptom management, we want to look at what types of symptoms are the patient having or is the patient having based on the problems that we have that you have identified for that patient. So symptom management could be physical therapy based on the fact that they're having pain. It could be physical therapy again based on the fact that they can't walk more than 10 feet. It could also be looking at side effects from medications and how to manage those side effects. The next thing that we have then is planned interventions. Now, this is going to be a couple of things. For your chronic care management and complex chronic care management, you're going to be looking at preventive services in addition to services that other practitioners involved with the patient's care have planned for them. So for an example, as part of your planned interventions, you can have in your care plan, the patient is due for their next annual wellness visit in August. So what that does for you then is in July, when you're providing the service, you can mention to the patient, hey, don't forget, you have this annual wellness visit scheduled on such and such date. And then in either August or September, you can say, hey, how did that annual wellness visit go? Did you meet with the provider? What was the information they gave you, etc.? You want to be talking about flu shots, their pneumonia vaccines, colonoscopies, mammograms, all of the preventive services for which Medicare will make payment. But you also want to look at what things do you have planned for that patient, or what things do other practitioners have planned for that patient? The cardiologist wants to do some type of testing again in August. Your July visit, your July encounter, again, non-face-to-face service, we'll talk about that. Do you have any questions on that? Do you have transportation for that? Don't forget it's going to be on the 12th at 10 o'clock. And then following that, either August or September, well, how did that go? Do you have, and then for your offices, do you have those test results? And are those going to make a difference in the care plan that you have for the patient? And then the last one there is, or last one on this slide is medication management. As Dr. Vahakas talked about, most of the patients under Medicare are over age 65. We also do have patients who are disabled and have been disabled for more than 2 years. But you get patients who have a lot of care fragmentation, and the medications really are not working together. Medications can cause cognitive dysfunction when they're not working together. Medications can cause other symptoms or other problems. So as part of chronic care management, excuse me, you're really going to be looking at all of the medications, all of the supplements, any herbal things that the patient may be doing, and really evaluating those. Are they needed for the patient? Is this the right medication for the patient? Is this medication working against this other one? What changes do we need to make, if any? And then you'll be talking to any other practitioners also to get their input. If you decide you want to change a medication, for an example, that the cardiologist ordered, have a conversation with them. Let them know you want to change this. Here is why you want to change this. And then decide, again, you're acting as the coach, what do we need to do from there? You also want to be, yes.
Ellen, I have a couple of questions that I'm wondering if I might ask now before we move on to new information.
Sure.
The first one, and I don't have the hand to raise today for whatever reason, so I apologize for interrupting you. First question, can a care management company complete any portion of G0506? You talked about that a few minutes ago. My understanding is that this must solely be completed by the provider or QHP. Can you answer that, please?
Yes, that G0506 procedure code is only for the billing practitioner. It is where the billing practitioner, that MD or DO, non-physician practitioner, is doing the comprehensive assessment, and they are developing the care plan.
Perfect. Two more questions. Great question. Can CCM services be provided by any specialty provider, or should this be completed by the provider that is truly managing the patient overall, such as PCP or internal med?
For chronic care management and complex chronic care management, these are generally going to be your primary care, internal medicine, etc., but it's not restricted to them. It's providers who can provide the service. OBGYNs, for an example, is a good example of a provider who may be doing this service. Oncology providers is another example. But if you're not kind of the primary care provider, you just want to make sure that you really are taking responsibility for CCM or complex CCM of all of the components that we're going to talk about. Generally speaking, for principal care management or PCM, this is generally going to be specialist, but it does not have to be. A primary care provider can do that service also, again, as long as they are meeting the requirements.
Thank you, Ellen. I think the next question is one that you're going to cover in just a couple of minutes. So I'm going to hold off on that question and I will pose it later if needed. Thank you.
Okay. So the next part of your care plan that you want to be looking at is the patient's environment. Are they homeless? Do they have a home that is safe? And we're talking safe not only physically, but also from the other people in the home. Are they afraid of someone in the home? And what are actions that we can take on that? When you're looking at their environment, for an example, before my mother passed away, she actually moved in with us, not because she could not take care of herself, but because she had 13 stairs going into her front and back door, and she simply could not do those stairs anymore. So that's a question and kind of what you want to talk about with that environment. Dr. Vahakas also mentioned food deserts. Where the person is living, Do they have access to a good grocery store where they can get the good fruits and vegetables? Do they have transportation for that? The next one then is a caregiver assessment. So the first question is, do they need a caregiver? If they don't, you're just going to document that and then continue on. If they do need a caregiver, do they have one? If they have one, is that person capable, both mentally and physically, of providing the care that that patient needs? You know, the one example that we see quite often is the little bitty wife, you know, not even 5 foot, with the 6 foot husband. Well, can she really help him get up out of a chair? Can she help him move to the bathroom, etc.? So you want to document that information. And then for social services, this is where Dr. Vahakas referenced looking outside of your office for community organizations that can assist your patient. Your patient, maybe they're dealing with depression symptoms. Okay, do you have a senior citizen center where they can go and they can meet with people, have a meal, that type of thing? Is your patient having nutritional issues? Do you have a Meals on Wheels within your organization? Um, a lot of times hospice agencies will do grief counseling. So if that's a situation that your patient has, then maybe that's a good resource for you. But you want to look at the other uh, community organizations, faith-based organizations that can assist you with your patient. And then you want to revise the care plan. Okay, you have to do a periodic review, which is at least one every year. You start your patient in July, you develop your care plan in July. Then next July, you need to do a full review of that care plan. But you also want to update it as needed. So when we're talking about updating the care plan, we're really talking about changing the care plan. So if your care plan, for an example, identifies, you know, 5 problems, and then in this month your patient adds a new problem, then you need to update the care plan. And all of those things that we've just talked about will need to be added into that care plan based on that new problem. And then you'll share that care plan with the patient, share that care plan with any other practitioners that are involved. And of course, this just mentions sharing of that care plan. Now, again, we talked about earlier that you can use a paper copy for your patients. You can use your portal, but really that's kind of your patient's decision. If they want it in writing, you know, so they can hold on to that piece of paper, then you want to provide it to them in writing. If they're okay with you putting it in the portal where they can access it, and their caregivers, et cetera, can access it, that's fine too. And then you want to share that care plan with other providers. And that sharing is a two-way street. You're going to share the care plan. You want them to share with you information from their encounters with that patient. And then the others listed there could be community organizations, could be the physical therapist, occupational therapist, etc. You just want to make sure that you're complying with the Health Insurance Portability and Accountability Act, or the HIPAA Act, when you're sharing information with other organizations where you don't have that understanding that that information is going to be comprehensive. So the next thing that we have is the monthly service. So this is what you'll be doing. So in that monthly service, there's all kinds of things that go into the time that you can use to choose your procedure code. And we'll show the procedure codes and the time requirements actually next. So for an example, if you call that patient on Tuesday and you say, you know, hey, Bill, how are you doing? And you're going through the care plan and you're talking about things that Bill has been doing things that you've been doing, providing updates to labs, all of that kind of stuff. All of that time counts. So, however long your phone conversation is with that patient, then you want to record that time. The other time that you want to record, though, is that work where you reviewed that lab. And what exactly does that lab result mean? Does it mean I have to do something else? Count that time. You're reviewing the notes from the last encounter with that cardiologist, and you're looking at those notes to see, do I need to bring the provider into this? Again, this is clinical staff services for the most part, and you're updating your care plan or revising your care plan as needed. You're adding information into that, and you're really reviewing that in order to get a good handle on your patient. That's work you did for that patient, and therefore that is time that you can count. You need to go in and you need to add information to the care plan. Well, that's time that you have spent on that patient. You took a call last week from that patient where they had a question on whatever they had a question on. That's time you spent on that patient. So in your documentation, you want to identify the activities and all of that work that you're providing to the patient. And then, of course, you want to identify the time. You're going to be looking at that care plan. You could be updating, which is kind of a more formal type of situation. You could be doing that periodic review, or you could simply be um, reviewing that care plan to see whether or not there's any changes that are needed. And then you need to document the person who is providing the service. As we've talked about, generally speaking, this is going to be your clinical staff. So your clinical staff are the ones who are going to sign off on this. Your practitioners, your billing practitioners are providing general supervision, which means that they don't have to be there when your clinical staff are doing the services. They don't have to sign off on the medical record or the care plan or any of the activities. And then this is a monthly service. So you want to bill at the end of the month. And the reason why you want to do that is so that you can capture your correct codes and capture all of the time that you have spent on that patient during that month. So here are the procedure codes for you, and these are the principal care management codes. But I want to draw your attention to the left-hand side of the page, which is practitioner code. So number one, this is only time spent by your practitioner. Time spent by anyone else does not count toward your practitioner time. In addition to that, you have to meet 30 minutes. So it has to be at least 30 minutes. This is not a situation where you can round up. Your best practice is to actually document how many minutes. It's not your best practice to simply say, I did over 30. Well, how many minutes did you do? That's your best practice. And then the second procedure code there, the 99425, this is each additional 30 minutes that your practitioner spends on that patient. And again, you have to meet that time in full. Now, on the right-hand side of your screen are your clinical staff procedure codes. And you can see for principal care management, again, it's 30 minutes, and then each additional 30 minutes. Now, a couple of things to think about here. Number one, you can't bill both of these within the same month for the same patient. You can only bill a practitioner code or only bill a clinical staff code. Now, I've already mentioned that your clinical staff time cannot count toward your practitioner time, but your practitioner time can count toward your clinical staff time. So for an example, your practitioner spends 10 minutes reading through or answering questions or having a conversation with the specialist, And then your clinical staff spends 20 minutes contacting the patient, relaying information, working with the patient on how they're meeting their goals, etc. Then you can submit that 99426 procedure code because you have 30 minutes, but you need to bill it under the clinical code, not the practitioner code. So the next thing that we have are the procedure codes for chronic care management. You can see your practitioner codes are 30 minutes, your clinical staff codes are 20 minutes. And then we get into the procedure codes for complex chronic care management. And you'll notice that your procedure codes for your practitioner are the same codes as what was on the previous page. For complex chronic care management, what has changed is your clinical staff codes. So you can see there that 99487 is the first 60 minutes of services. When we're talking a complex chronic care management service, it is really a more intensive, and I guess I want to say kind of harder service that you're providing to the patient. We have all kinds of YouTube videos available out on our YouTube channel. One specifically is on complex chronic care management, and then we have another one specific to principal care management. But you can see here you have to meet 60 minutes, and then for the 99489, each additional 30. And again, you have to meet the full time, you can't round up. And then
Ellen, I have a couple of questions, if I can scoot in here real quick. And again, I apologize, I can't raise my hand, it's not available. First question is regarding the CCM procedure code. For patients who have not been seen by their provider that month, or have not been seen by their provider for a couple of months, but receives a call for their CCM, what services or information would qualify or justify the 20 minutes spent within the patient's chart, adjusting the patient's plan of care? This would be for the clinical staff. Our CCM is through a third party, and curious on how the 20 minutes is justified when a patient does not answer the phone for that month.
well, if you don't have documentation of at least 20 minutes that has been spent on that patient, then you can't bill the service. So, if the patient doesn't answer the phone and other work that you provided for that patient for that month don't add up to that 20 minutes, then you would not be able to submit that service.
Okay, great. One more question before I let you continue on, if you will. The question, complex CCM cannot be completed by a care management company. Is that correct?
No, that is not correct. A care management organization can do that. One of the things that we have with the complex chronic care management is that there has to be medical decision making during that month of moderate or high complexity, and that's going to be by your billing practitioner. That does not have to be face to face. So, for an example, if you're doing complex chronic care management and your physician is evaluating it, again, we'll use the notes from the cardiologist, and they're having to make a medical decision for that patient, and this would go based on the moderate or high complexity medical decision making as described by the AMA, then that counts. You don't have to have an in-person visit during the same month as you have chronic care management. And really the purpose of chronic care management is that the patient doesn't have to be seen as often. Obviously, that's going to be a clinical choice, how often your physician needs to see that patient. But the goal from chronic care management is really that the patient does not have to be seen as often by that billing practitioner. And The care management organization is clinical staff. And so a care management organization cannot, and clinical staff in your offices, your direct employees, they cannot be the ones making that moderate or high complexity medical decision. It is only that billing practitioner, the physician, the MD or the DO, or the non-physician practitioner. Do we have other questions?
I'm seeking some clarification at this point, Ellen. So let's circle back to that question, or the question that I'm working on with one of the learners, and we'll come back to it. Go ahead and proceed.
Okay. So what you have up on your screen right now is the procedure code that encompasses chronic care management, complex chronic care management, and principal care management provided by the RHC Rural Health Clinic and federally qualified health center. It's that G0511 procedure code, and that's all of it. We also have a YouTube encore presentation out there that is directed to RHCs and FQHCs that goes into more detail on how they bill for the service. And then the second part of your screen on the right-hand side is that for RHCs and FQHCs, this is not part of their all-inclusive rate or their prospective payment system. They can bill for this and they get paid separately for this. And it is payable under the physician fee schedule amount. So just some additional reminders here. Again, time has to be met or exceeded. Practitioner time can count toward clinical staff time. Clinical staff time cannot count toward practitioner time. Now, one of the questions we receive quite often has to do with, well, how does a resident play into this? Well, a resident plays into this as clinical staff time. Medicare reimburses teaching physicians for services done by the resident in two situations. One is when the teaching physician is physically present when that resident is providing those services. Well, that's not a situation we would see when we're doing these non-face-to-face services. Or we reimburse the teaching physicians under the primary care exception, and this service does not fall under the primary care exception. So then the next slide that we have is just kind of other information. Mary has placed into the chat the MLN from CMS. She has placed into the chat the playlist link for all of the chronic care management YouTube videos that we have available. We have some shorter ones. We have some encore presentations from previous webinars that we have done. So you can take a look at that. And then you also received, or as one of your handouts was a timely topics document. So I encourage you to take a look at that and the information that we have available for you. What you have up on your screen right now is the survey. You can either use the link or you can use your smartphone or smart device to use that QR code. We really do ask that you complete the survey. This is part of our reporting to CMS. We use this survey and your responses to that to evaluate our actions in providing education to you. If you think we were fantastic today, please tell us that. If you think there's ways that we can improve, please tell us that also. In addition to that, as part of that survey, there is a section there asking about additional education that you would like to see. We gather this from all of the surveys that we receive, and that's part of how we determine what education we're going to do in the future. So we do encourage you to complete that. So the next thing that we'll go on to then are questions. Mary, do we have any additional questions?
We do not have additional questions at this time, Ellen. I'll continue to monitor.
Okay. As Dr. Vahakas talked about, chronic care management really is a fantastic service, both for your beneficiaries and for your providers. We have talked to a lot of different providers who are doing this service, providers who are getting ready to do the service, etc. And what we have heard from them is once you kind of get over the hump, which is getting those workflows in place, determining how you're going to capture your time and your activities, having those conversations with your patients on what this means to them and how what's the word that I want to use, how interactive this is going to be for that patient. They're going to be getting contact from your clinical staff generally on a monthly basis. So that's showing that patient, this provider's office, they care about what happens to me. They're helping me to meet these goals. They're paying attention to everything that's going on with me. Plus, your care plan is providing information for the patient to do. I want you to exercise 3 times a week. I want you to have fruit, once a day, or a glass of juice, or whatever your instructions are to them. And then in those interactions, your clinical staff and your patient, the trust that they have between each other, they can really have those conversations to help improve the problems and improve that patient's quality of life. So Mary will ask again for any additional questions.
There are none at this time, Ellen.
Okay. Then just a couple of housekeeping things. Again, we ask that you, complete the survey. Once you close out of the webinar, it will take you to a page. It has a little yellow triangle on the top and then a continue button. It's not spam or anything like that. It's just telling you that if you hit the continue button, you will go into the survey. We set that up with WebEx so that you have an opportunity to take the survey there. And then I saw that Mary also put into the chat our wps.gha.education@wpsic.com. If you have follow-up questions, you go back and you give this information to your physicians and practitioners, your office managers. If you develop questions within 10 days from today's presentation, then send it to that email box and we'll be happy to respond back to you. So Mary will ask once more.
There are no questions.
Okay, then thank you so much for attending today's presentation. We really appreciate that, and you have an absolute wonderful day. And this will now conclude our presentation.